This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hello, this is Dr. Deepak Megur, and today I'll be discussing the basics of four-quadrant technique, the divide and conquer technique. Through this case, I'll just take you through this unedited video. She is a 70-year-old lady. Let me pause the frame here, and the cornea is not great. We have a very thick arcus. We have a small pterygium here. The visibility is not great, and to add on, we also have pseudoexfoliation. The pupil is reasonably well dilated. The underlying cataract is grade 5 brown cataract, and these cases are challenging. You need to be concerned about the endothelial damage in such eyes. The eyes with these thick arcus, they also have higher incidences of descendant membrane detachment. That's what I have noticed in my practice, especially these elderly patients. So we need to be aware of all the potential issues which can arise from this case. The two side ports are done. The staining of the anterior capsule is extremely critical in these eyes because we want to have an adequately large rhexis, and these eyes, the visualization is a challenge in these brown cataracts, so staining does help. And take a couple of seconds more to ensure that the dye is evenly spread. The capsule is very well stained. The antechamber is pressurized with dispersive OVD, and the main incision is now being created. The globe is stabilized with the stabilizing ring. Eyeball is pushed slightly away, and I have a 2.8 millimeter limbal based incision. Ideally, in such cases, I would prefer a slightly bigger rhexis. I am aiming at 5.5 or probably 6 millimeter rhexis in this patient, and the advantage of having bigger rhexis in such eyes is that there will be a lot of stressful maneuvers happening during nucleus management, and if you have a bigger rhexis, there is less a chance of inducing any stress or traction on the rhexis margin. This is the reason why it's advantageous to have a bigger rhexis when you're dealing with these dense cataracts. I have an adequately large capsular rhexis opening. Hydrodissection has to be very gentle in these eyes because the posterior capsule also is going to be very thin in these, and we don't want any pressure to build up within the capsular bag. Use very small amounts of fluid and then decompress at multiple quadrants to ensure that you don't increase the pressure inside the bag. I'm just confirming the mobility of the nucleus so it is free from its capsular attachments. Time to emulsify the nucleus. As I'm introducing the phaco tip into the eye, let me freeze the frame here and let me show you one important thing. The tip is exposed slightly longer than what I usually do. So when I'm dealing with harder cataracts, I ensure that the tip which is exposed is slightly longer. This helps us to create longer grooves, and there is no obstruction obstruction to the sleeves by the narrow trench. To begin with, the superficial epinucleus and cortex is aspirated, but there is hardly any to do so. The settings are switched on to the sculpt mode. These are the settings which I'm using. Important thing to note is the flow rate is extremely low, as is the vacuum, and the power is higher. So it's almost 90% power you're using in continuous torsional mode. One of the key mistakes which most beginners surgeons make is they're trying to sculpt. The nucleus is invariably being pushed around. This should not happen. So the best way would be to know you have to use adequate amount of energy, and the energy itself should ensure that the groove is being created, not the biomechanical force. I'm using the second instrument to stabilize the nucleus, and I'm making these groove. That also helps to minimize this jerky movements on the nucleus. Please remember that the groove is being created not by the mechanical force which you're using, but it is because of the ultrasound energy. If you really push and tug more at these nucleus, you're going to induce enormous amount of stress on the zonules in the bag. So be mindful of this and use the right amount of power for these cases. As the first two sculpts are being done, you can see that there is a small amount of nudging which is happening to the nucleus. The nucleus is moving around. This is because of the sleeve which is getting entangled with the walls of the groove. The groove is not wide enough to allow the entire sleeve to go inside. So as I'm trying to go in, the sleeves are being obstructed by the walls of the groove. That's the reason why the nucleus is wobbly. So if we want to create a deeper trench, the grooves have to be slightly wider so that they allow the sleeves to get in. So when you created a groove, there is always a situation where if the groove is too narrow, you cannot make a longer trench simply because it is obstructed by the sleeves. So ensure that the groove is just big enough to allow the sleeves as well. We don't want an unusually wide trench as well. If you do a very wide trench, then it creates an issue when you're trying to laterally separate them. So the reason we need to have a narrow trench, but it should be just wide enough to allow the sleeves. So that is what we should be mindful of. Slowly and steadily, the nucleus is rotated 90 degrees, a fresh trench is created, and this process is kept on repeating until we reach 90% depth of the nucleus. This is critical, especially when we're dealing with these brown cataracts. Once we have evidence that the depth is sufficiently deep, now we need to try to do the lateral separation maneuvers. You can use two long Sinskey hooks to do the lateral separation, or the phaco tip and the second instrument in my left hand, that also can be used. That's what I'm trying to do it. It's important to keep the phaco tip as closer to the bottom of the trench as possible, and then using the second instrument you do the lateral separation maneuver. The only secret to achieve an efficient crack without using excessive amount of force is to place these two instruments as deep as possible. So in this case, my lateral maneuvers are slightly more than what I would have liked. Maybe I shouldn't go beyond the central, maybe 5 millimeter. When doing lateral separation, it's important that the second instrument should not go beyond the 4.5 millimeter diameter. So if it goes beyond that, then there is always a risk of tugging at the rhexis margin. In this case, the rhexis margin was slightly bigger, it's alright. But still, as a practice, we should be mindful that the laterally separating instruments, they should not go beyond the 4.5 millimeter zone. That should be our goal. So now the 4 quadrants are divided. Now is the time to emulsify one by one. The first quadrant is pulled out of the bag and then emulsified. During the quadrant removal mode, one has to be very careful because this is the stage at which we are nearer the endothelium. The most of the corneal endothelial damage happens during this stage. So we need to be mindful that we shouldn't induce any lens chatter or turbulence during emulsification. Use the right amount of power, and secondly, be in the right plane. Don't be near the cornea. It's better to be near the pupillary plane, and always ensure that the fragment is dancing around the tip. And when the tip is moving around, we should know that we can observe that it is at the level of the pupil. When we're in the central safe zone, that is the place where we have maximum depth, we should be focused on keeping a probe dead center when you're doing this quadrant removal. So because this is the deepest part of your anterior segment, the central safe zone. The cornea is farthest away, as is the posterior capsule. So if you're emulsifying in the central safe zone, more likely than not, we are able to prevent any endothelial damage. The last fragment is emulsified. Time to remove the cortex. So very little cortex is there to be aspirated. It is done, and now is the time to implant the lens. So it's important to remove OVD from under the lens, and here I'm going only with the irrigation cannula. We're not using any aspiration, only irrigation. It just goes under the lens, and the irrigating fluid itself washes away all the OVD which is in the bag and also which is sticking onto the back surface of the lens. You just have to wait for a minute for the entire OVD to go out, and then similarly I'm irrigating out the OVD which is in front of the lens. So time to close. The side ports are hydrated. That's it, the case is done, and these are the first day post-op pictures. So when you're dealing with these hard cataracts, there's a common misconception that the divide and conquer, we're using a lot of energy and that causes a corneal edema post-op. Well, it is not so actually, because when you're doing this divide and conquer technique, the energy which is being used during sculpting is directed towards the nucleus, and it is being delivered within the bag. It is very far away from the corneal endothelium. So in my experience, I have not encountered corneal edema because of excessive use of energy. The most common reason for corneal edema invariably would be a mechanical trauma because of the hard fragments hitting the endothelium. So the division is done in the bag, and then each of these fragments is emulsified in a controlled manner at the pupillary plane or rhexis plane. So we are very much far away from the corneal endothelium, and if we are patient enough, if you replenish OVD after emulsifying every fragment or every couple of fragments, be rest assured that the cornea would be pretty clear the next post-op day. So these were a few tips on managing a hard cataract, and that's it. Thank you for watching, and hope you found this helpful.